Greetings for the day, folks. Today we are going to discuss about management of hepatorenal syndrome. So, in the management, we have to take measures to control the and prevent variceal bleeding. So, for that, we give beta blockers and band ligation under endoscopy and pentoxifylline for severe alcoholic hepatitis. And for the prevention of HRS, we must avoid intravascular volume depletion. So the drugs causing like depletion should be avoided, like diuretics, lactulose, GI bleeding, large volume paracentesis without adequate volume depletion, then judicious management of nephrotoxins like ACE inhibitors, ARBs, that is angiotensin receptor blockers, NSAIDs, and antibiotics. So prompt diagnosis of infection and also SBB prophylaxis should be done. So this prevents the HRS development. So if the patient develops HRS, then we must treat the HRS, right? So we must stop all the nephrotoxin agents. Then we must give antibiotics for infection. Then albumin, which at the bolus rate of like 1 gram per kg per day on presentation, and maximum dose is 100 grams daily. So it should be continued at a dose of 20 to 60 grams daily as needed to maintain central venous pressure between 10 to 15 centimeters water. And also vasopressor therapy in addition to albumin. The usually we give terlipressin. It is not available in USA, but it is available in other countries. So terlipressin should be started at 1 mg every fourth hourly, and it can be increased to 2 mg IV fourth hourly. And if the baseline serum create does not improve by at 25% by 25% on day 3 of therapy. So we can increase the dose. Or else we can use the midodrine or octreotide. Midodrine can be started at like 2.5 to 5 mg orally twice daily, and it can be increased till 15 mg thrice daily. The MAP should be increased at least 15 millimeters of mercury, and octreotide is usually given at 100 micrograms subcutaneously 3 times daily, and it can be increased till 200 micrograms subcutaneously 3 times daily. Or else we can give a 25 micrograms bolus, then we can start on the infusion at 25 micrograms per hour. And if and also the because the vasopressors other vasopressors used are not a peripherin, that is at zero point 0.1 to zero point 0.7 micrograms per kg as an IV infusion, and can be titrated up by 0.05 micrograms per kg per minute and every fourth hour. The duration of and the map should be at least increased to at least 10 millimeters of mercury, and the duration of the vasopressor is generally a maximum of 2 weeks until reversal of hepatorenal syndrome is seen. Okay, and patient should be evaluated further for the liver transplantation. Thank you very much. This concludes our